Bismillahirrahmanirrahim. I'm Major Sumbal. Welcome all of you on behalf of A5P team on this multidisciplinary meeting on the newborn and maternal screening program. First of all, I would like to invite Brigadier Asif Nawaz for the recitation of Holy Quran.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم لو أن أهل القرى آمنوا واتقوا لفتحنا عليهم بركات من السماء والأرض ولكن كذبوا فأخذناهم بما كانوا يكسبون أفآمن أهل القرى أن يأتيهم بأسنا بياتا وهم نائمون وآمن أهل القرى أن يأتيهم بأسنا ضحى وهم يلعبون सदक़ अल्लाह रज़ीम। सूरह अराफ में लफ्ज़ गुर्बत फरमाते हैं कि काश ये बस्तियों के लोग हम पर भरोसा करते हुए हमारा निज़ाम इख्तियार कर लेते तो हम ज़मीनों आसमान के ख़जानों के मुंह उन पर खोल देते, लेकिन अफसोस कि उन्होंने तो हमें ठुकरा दिया। सो हमने भी उन्हें उनके करतूतों की वजह से तरह तरह के अजाबों में घेर लिया है। क्या बस्तियों के लोग बेखौफ हो गए हैं कि हमारा अजाब उन्हें रात नींद की बेखबरी में आन पकड़े या जब दिन में वो खेल तमाशे में पड़े हुए हों। सदक़ अल्लाह रज़ीम।
Jazakallah. Now I would like to invite Brigadier Naveed Asif for the welcome address.
Bismillahirrahmanirrahim. Most respected Brigadier Munir Lodi, HOD and Advisor in Pediatrics, Professor Asim Mumtaz, newly elected President, Pakistan Society of Chemical Pathology, Brigadier Shaila Wakai, HOD and Advisor in Gynecology, honorable guests, ladies and gentlemen, I welcome you all to the multidisciplinary team meeting. The purpose of present gathering today is to explore the feasibility of launching screening program for newborn and expected mothers. In whole of the developed world and in some regions of our neighboring countries, such programs are essential part of the health services. Newborn screening means testing every child who is born in a community or regions should be tested for certain diseases according to the epidemiology of the disease in that particular country. Brigadier Amir Ijaz will elaborate on various aspects of this program as it is being launched in our setup. Maternal serum screening means carrying out certain tests in the mother's blood to get an idea of the well-being of the baby to be delivered. We plan to launch a pilot project to obtain the basic data before a proper program can be started. Major Safia Fatma will give you some details of this project. For the last about 15 months, we are performing some tests to diagnose inherited metabolic disorders in newborns and infants. Please note that this diagnostic service is different from the newborn screening program. Lieutenant Colonel Aisha Hafiz today will present some interesting cases which have been diagnosed with these tests. But the most important part of Colonel Aisha's presentation is launching of a novel score which we may present to rest of this world for the diagnosis of IMDs. We will also like our pediatricians and gynecologist colleagues to give their perspective about these programs. I hope you will enjoy the proceeding of today's session and will continue to communicate with us in future too. I thank you all for your coming today. Thank you.
Just to Dr. Ali, from ZB Foundation, and they will also give a talk because they are offering a free of cost newborn screening program for thyroid disorders, and we will also discuss that. Thank you.
Thank you, sir. Now I would like to invite Lieutenant Colonel Aisha Fees for a talk on inborn metabolic disorders and experience at FIP.
Thank you, Major Sombal. Bismillah Rahmanir Rahim. Worthy seniors, honorable guests, and my fellow colleagues, Assalamu alaikum. I'll use this forum today to share the experience of our team at Armed Forces Institute of Pathology in the diagnosis of inherited metabolic disorders. Well, the preliminary facilities for the diagnosis of these disorders, they were available at AFIP since long. But the actual journey of our team towards advanced diagnostic pediatric facilities, that commenced almost about 2 years back with the installment of a dedicated state-of-the-art amino acid analyzer for advanced pediatrics. The sequence in the next 20 minutes would be as flashed. I'll basically be discussing the preliminary as well as the advanced diagnostic facilities that are available at our institute, followed by certain facilities which are still in pipeline. And after projecting the actual IMD data of whatsoever cases we have diagnosed so far, I'll discuss, for the interest of the audience, a few of the most interesting cases. And then in the last, I will actually discuss the challenges that we've been facing in diagnosing these disorders. Now, inherited metabolic disorders, or IMDs as they are known as, that they as a group are not very rare, and the incidence being 1 in 800. Early recognition of signs and symptoms, prompt evaluation, and referral to a center which is specialized in management and diagnosis of these disorders, that results in an optimal outcome for these cases. Now, we have certain impediments or challenges in diagnosis, being non-specificity of the signs and symptoms. Then there's a need of exclusion of routine childhood illnesses in the first place. And we know that often these biochemical interrelationships, they are very complex. So there might be unfamiliarity with these disorders. And lastly, the most important aspect is that inappropriate sample collection or sample storage, they may actually hamper the true results. So we have to take care of all these aspects when we are actually diagnosing these disorders. Now, these were the basic facilities which are available with us. And we recommend that some of the investigations like arterial blood gases, plasma ammonia, lactate, maybe liver function tests in some cases, and these urine for reducing substances. They, at minimum, they should be carried out as a preliminary investigation in all of the cases. And I remember that this point was also highlighted in our first MDT meeting, which we held with our colleagues in pediatrics almost 1.5 years back. Now, as I was already mentioning, the real breakthrough in these diagnoses that came with the installation of the amino acid analyzer, which is a state-of-the-art technique by high-performance liquid chromatography for the quantitative analysis of these amino acids in various biological fluids like plasma, urine, and CSF. This facility was installed at AFIP in the fall of 2015, and we have a repertoire of about 32 amino acids, meaning thereby that 32 amino acids and their metabolites, they can be tested in a single run. But currently, we are only reporting 23 amino acids, which are clinically significant. And most of the investigations and the cases, they have been solely diagnosed on the basis of preliminary investigations as well as the results of amino acids. And just for the interest of the audience, this is basically a chromatogram which I'm showing over here. And you can see the glycine peak. This was our first case of IMD which we diagnosed. Then a phenylalanine peak in a case of hyperphenylalaninemia. And then most recently, we have diagnosed a case of maple syrup urine disease. I'll discuss these cases later on in a little detail. Now, this triple quadrupole LCMS, liquid chromatography mass spectrometry, this is another state-of-the-art analyzer, and let me tell you, it's a very powerful analytical technique, and it combines the resolution power of chromatography with the detection specificity of mass chromatography. And we are currently using it for a number of assays, but as far as diagnosis of IMDs is concerned, we are quantitatively performing methyl malonic acid, which is one of the organic acids, in biological fluids like plasma and urine. This facility was started in January last year, and up till now we have diagnosed 2 cases of methyl malonic acidemia. This is the chromatogram of one of the cases of methyl malonic acidemia which we diagnosed. And then we have acquired the library for 56 organic acids. This is basically, we'll do it on gas chromatography, mass spectrometry, and qualitative analysis would be performed in urine. However, the standards, they are still in the process of procurement, and we'll be starting this facility, inshallah, within a period of 2 months. This was the organic acids library along with its test repertoire that I was talking about. And then we know that the diagnosis of these fatty acid disorders that has been much simplified by the assays of plasma acyl carnitines, because we know that these acyl-CoAs, whenever they are proximal to the block in fatty acid oxidation disorders, they get trans-esterified to carnitines, right? So we can very conveniently diagnose most of the fatty acid oxidation disorders on the basis of plasma or less commonly urine levels of these acyl carnitines. However, the current problem we are facing is that the ESI source, which is basically the source of ionization in our current equipment, that does not have the desired sensitivity for these plasma acyl carnitines because they are very complex structures. So we are in the process of procuring another source, that is APCI, atmospheric pressure chemical ionization source. And this facility would also be started. One of the achievements of our team was the publication of guidelines on inherited metabolic disorders. And when we launched these guidelines in the 7th biennial workshop of Pakistan Society of Chemical Pathology, these guidelines can be used as a ready reference by our colleagues in pediatrics as well as our own trainees and consultants for the diagnosis of IMDs. Now coming to the actual data. From September 2015 up till December 2016, we received a total of 330 cases for the diagnosis of inherited metabolic disorders. And out of these cases, 29 cases were diagnosed. And let me tell you at the outset that these cases, they have been purely diagnosed on the basis of, by correlating the clinical features, the results of the 5 to 6 initial or the basic investigations which I was mentioning, as well as the results of plasma amino acids. And in the case of methyl malonic acid, it was based on the levels of MMA, the quantitative levels of MMA. As you can see from here, most of them, they are amino acid disorders. However, a few like urea cycle defects, congenital lactic acidosis, glycogen storage disease, and mitochondrial disorder, they were also diagnosed purely on the basis of history and initial biochemical findings. Then a few cases of IMDs which we diagnosed. This was a really interesting case of late onset non-ketotic hyperglycemia. We worked it in collaboration with our colleagues in pediatrics. And this case report has recently been published in Pakistan Journal of Pathology as well. We received an investigation from an 8-year-old child who had presented with serious hypotonia and drowsiness along with fever. He was born to consanguineous parents, and he had a history of post-meningitis series at 4 years, followed by development of optic atrophy at 5 years of age. And he started developing muscle weakness, so much so that when he reached his 8th year of life, there was loss of weight bearing on the lower limbs. And of course, the family history was positive, as was the neurological examination. And this child had all the 3 features of this spastic diplegia, chorioathetosis, and optic atrophy. And also, however, the initial biochemical investigations, they was mostly normal, but the MRI, it revealed marked cerebral as well as cerebellar atrophy, and so was the EEG. It also showed an abnormal bizarre pattern. And this was the actual plasma amino acid analysis. As you can see from this report, the plasma glycine levels per se, they were not very markedly elevated. There was only a marginal rise in plasma glycine. However, when we correlated it with the urine glycine levels, the urine to plasma, the CSF glycine levels, the CSF to plasma glycine levels, that was beyond and the cutoff for diagnosis. So based on these clinical features and the results of initial findings, and especially the ratios of CSF glycine to plasma, this child was diagnosed as a case of atypical or late onset, because you see, this is not the normal age of presentation for a case of NKH. Usually they present in the newborn period. Then the second case, it was also recently diagnosed, of a 9-year-old child presenting with cirrhosis and rickets. He was basically admitted at MS Rawalpindi for surveillance of a GI endoscopy. He had had multiple investigations, but a final diagnosis was yet to be reached. There was a history of delayed milestones and multiple fractures between ages of 1.5 to 4 years. And most of his initial biochemical findings were deranged. Therefore, we received a request for this plasma amino acid analysis by IEC. This IEC is basically ion exchange chromatography. In fact, this is a form of HPLC, right? So you can use both the nomenclatures for them. Here you can see that there were raised levels of some of the amino acids like tyrosine, phenylalanine, and methionine. Well, this could be a feature of a non-specific liver disease as well. But when we correlated it with the clinical history as well as the features of cirrhosis and rickets, we had a strong suspicion of type 1 tyrosinemia. And hence we committed it in our report as well. And later on, it was confirmed to be a case of type 1 tyrosinemia by urinary succinyl acetone levels, which turned out to be raised. The facility is currently not available with us. We outsource these investigations. And this is the plasma chromatogram we had, followed by, you can see raised levels of tyrosine and other amino acids. And the third case, which we have diagnosed only very recently, about a week back, was that of a 21 days old newborn child who was admitted in NICU MH. He had had history of lethargy and refusal to feeds. We received blood and CSF for amino acid analysis because the clinicians were strongly suspecting some IMT. And as per clinical details provided, the baby had shallow breathing and was dehydrated. Now, as you can see from here, most of the initial biochemical investigations, they were deranged. And this is what we got when we ran the amino acids on high-performance liquid chromatography. This biggest peak, which you can see over here, is the unmistakably high peak of leucine. Well, this case was also posing a diagnostic challenge because we did not receive as markedly high levels of isoleucine and valine. Rather, the valine levels were much within normal limits. But, a detailed research of the literature later on revealed that it is basically the ratio of leucine, the concentration ratio of leucine to other amino acids that is critical in the diagnosis of MSUD. So based on these, we diagnosed it as. Then we received the CSF amino acids as well. They showed the same picture. We had elevated levels of leucine and isoleucine. And when we combined all these findings, we labeled the case as maple syrup urine disease, that of maple syrup urine disease. Now, later on, urinary amino acids were also requested. Well, actually, the actual diagnosis is based on the analysis of the corresponding keto acids in the urine. We don't currently have the facilities for analyzing keto acids, but just for academic purposes, we asked for a fresh urine sample. This also had a very interesting finding. In addition to leucine, isoleucine, and valine, we saw multiple peaks that showed raised levels of other amino acids as well. So probably this child was having an additional Fanconi defect as well. Now, the actual challenges. When we started these investigations initially, the biggest challenge was that very often the complete battery of preliminary tests, it was quite often not available for interpretation, especially for the cases which we received in outdoor. But this problem was solved at multiple occasions through repeated communications with our colleagues in pediatrics, because we believe that provisionally diagnosing these IMDs, that requires constellation of certain biochemical findings, rather than basing your interpretation on a single result. So the clinical correlation and correlation with initial findings is very important. And the other major challenge is that, as I've already discussed, that these investigations, they have been done by correlating all the factors. Confirmatory or enzyme assays, which are the actual confirmatory tests, they are still not available with us. And from an analytical point of view, a major problem which we are currently also facing is the analytical interference from bilirubin. Because hyperbilirubinemia, what it does is that it causes analytical interference in the form of multiple peaks around the distillation times of various amino acids. And what we have learned from our experience of about 1.5 years of analyzing these results, that levels which are usually that is not a very strict case, 70 or less, they cause minimal or little interference. So what we have suggested to our colleagues in pediatrics is that analysis is either recommended to be carried out or repeated after bilirubin levels are settled. If you see, these were the multiple peaks. These are the chromatograms from 2 actual patients which we received. They were having very high bilirubin levels, and we were having multiple peaks. So we cannot really, very confidently exclude any IMT in such cases. And another case in which there was a transient derangement in amino acids due to bilirubin effect. What actually happened was that we received samples of a 10-day-old neonate who was admitted in ICU CMH with seizures. Well, Sir Talal is here, and basically he referred this case. He had a history of early neonatal death of a sibling, and most of the initial biochemical screen was positive, right? So that raised a strong suspicion of coexisting IMT. When we ran the plasma amino acid levels, we got very surprising results. Most of the amino acids, they were raised, but more so, if you can see, glutamine as well as the alanine. And most of the biochemical investigations along with this profile, they were quite suggestive of a possible urea cycle defect. But then we received a call from our colleagues in pediatrics saying that this report was not correlating with the clinical features of the patient. So we requested for another sample, and in this sample, as you can see, this was the result with an elevated bilirubin, and this is the result when we got another fresh sample. The bilirubin's levels and the clinical condition of the patient had settled by then, and so does the amino acid levels. So we've still, recommended monitoring of this patient with ammonia levels. Now, the last part of my discussion, I'm going to reveal a very important project to curtail unwarranted, expensive, cost-effective, time-consuming investigations, and to, focus our attention more towards detailed workup of cases, strongly suspected cases which truly merit workup. We are in the process of devising a novel clinico-biochemical score, which we intend naming as Rawalpindi IMD score or risk, right? So basically, this project, this has already been given to one of our trainees in FCPS, and will inshallah work in collaboration with our colleagues in pediatrics. An MOU would be, signed, and we would, for the purpose of publications, authorships would be decided mutually. So we really look forward to the cooperation of our colleagues in pediatrics to make this project successful. Now, what is this risk? What we have done is that basically we have selected 10 clinical biochemical parameters based on their relative abundance or the relative importance in diagnosing IMDs, and we will assess each child which reports to us, be it from the outdoor or indoor, for any suspected IMD on this scale. And this this is a scale, a score of total of out of 10. And each child would be assessed on a scale of 10. The consanguinity and the affected sibling or the positive family history, that has been given the highest score on this scale. And what we foresee and interpret and recommend is that any child with an IMD score of 2 or less is most likely at low IMD risk and should be observed and looked for some other causes of, the non-metabolic causes of his disorder. And those presenting with cases like between 3 to 5.5, they are at intermediate risk, and specialized investigations should preferably be done in those cases. However, all those cases who have this score of 6 or more, they are the cases which are truly at risk of these IMDs, and for these cases, sophisticated investigations are strongly advised. So that was all the talk on my part. Thank you very much for your active close listening. If you have any questions, comments, or queries, you are please welcome. Sir.
Thank you very much for
Thank you, sir.
very, very nice and noble presentation. I've just noticed that with regard to the various mutations that contribute towards
yes.
the inherited or inborn heads of metabolism, what's your
so that's what I was, that's what I was mentioning in the challenges which we are facing right now. We currently don't have, the confirmatory enzyme assays or the mutation assays for most of these diseases. But I guess in due course of time, we might embark, somebody from our department might embark upon that project.
And yes, which are also mutation analysis.
No, sir. Sure.
Actually, but one thing we must keep in mind that these disorders are mostly sporadic. They do not run in families. So, for research interest, it may be good thing to have mutation analysis, but you cannot use those mutation analysis for that because they do not run.
with regard to the insanity score?
Yes, the genes are running. The genes do run.
Genes do
there
run,
is a series that is high, but not for all cases. Like thalassemia or like diabetes, like such those disorders, because these genes are they do run in families, but cases are not.
In one of the cases, the methylene level was raised. What's your take with regard to the estimation of B12 folate and?
Sir, no. The B12 folate, they are actually important when we are diagnosing a case of methylmalonic acidemia. Because this methionine which I showed, that was a part of that IMG, or this is also a pattern which we see in non-specific liver diseases. So whatever 2 cases we have diagnosed so far, we did their folic acid, that was mentioned on the report. We did their folic acid as well as B12, and after excluding that deficiency, only then we labeled them as methylmalonic acid.
That this MMA test, methylmalonic acidemia, is very costly.
Very expensive. 1 million.
Expensive. And we are limiting it only to the for the classified senior because and we will not. We will repeat. I repeat. We will not use it for diagnosis of B12 deficiency because it's very easy to replace the result and
so is it available for all this test?
No, not at all. We second thing, these tests are not repeated, not available for adults.
Yes.
These are only for women.
सर मुकर्रम को मुश्किल सा सवाल मुझे लगता है पूछने लगे जी
to say that the confounding or interfering effect of Zerodin was the first time finding in your case?
No, sir. No. That, sir, I had, searched the literature thoroughly. But till date, there has been no reported interference in the form of multiple peaks. So that's what is the real challenge. We are currently also procuring the pure standards, and we run it as a project to see that at what level it interferes and what can actually, because abhi asal masla ye hai ki we have to see how to tackle with this interference, because most of these cases they are actually like somebody one of the colleagues in pediatrics saying ये cases ही basically आते हैं कुछ जो जिनमें jaundice होता है, so you cannot really sit and wait and
so if you establish this as a fact, you will be saving a lot of wastage of it.
Yes. So we have already recommended it to our colleagues in pediatrics.
Are we doing in cases of established junior cycle disorders and things like that? Would we be able to offer them antenatal?
No, sir. Antenatal is not.
CBS,
no, not yet.
Because these patients are were more than numerous patients. उसका भी करना बहुत मुश्किल है.
That is a huge issue. I was there. We are part of the team which is doing basically about the increased incidence of terminations and antenatal care. The problem is this, that if one child is diagnosed, उसका तो मुझे नहीं पता हम कुछ कर सकेंगे कुछ तो we would be able to do some things.
That must be a part of the genetic counseling.
Yeah. So there is no point of genetic counseling. The problem is that I face a challenge in this situation that I had a referral from a gynecologist. She says the first people diagnosed with XYZ disorder, and now you help this mother. We can't help this mother.
I think it's a huge leap forward when we are starting to diagnose and identify children with health advances. But still, the question knows, you see, we get referrals from pediatricians also, that this lady has to, and there's a strong background of consanguinity. This lady has two children with this disorder, and please do see this. They would say do see this. But we can't do see this, you see, unless we identify the mutation.
लेकिन कब
So the mutation is not identified, we cannot do the same. So those factors are all factors.
For index case, we can establish a mutation.
But for predicting the risk of application,
For this particular situation, we can develop. There is a possibility when we have an NGS with us and other instruments, we can establish that mutation and then we can use it for the yes. But not for the kernel diagnosis.
Can we check it out with the next?
Yes, we will do.
if the mutation is identified.
That is our aim.
NGS.
But if you wait for 1 hour or so, we have another extra presentation by the which is regarding the internal screening program for the purpose.
You see, what we would like is that when the baby dies, the pediatrician colleagues should give a diagnosis, whatever the suspicion was, so that we can have a look at it. You know what is happening now? There's a death certificate which says cardiopulmonary.
Yes.
That's the only thing given to us, and we cannot.
We cannot take auto prediction. It is our fault. We cannot
As a
diagnose.
team, we should be able to diagnose.
Thank you.
Who's going to already हम इंशाल्लाह एक और बुराई बोल रहे हैं हमारी बुराई में आगे एक और चीज बहुत जबरदस्त है इंटरनल स्क्रीन में वो भी हमारा प्रोजेक्ट के साथ है यस ये भी इंशाल्लाह स्टार्टिंग डूइंग सेल्फ डीएनए in mothers which is a purely non-invasive technique just in mother's serum we will check the fetal being and inshallah we will develop that maybe 1 or 2 years.
Just to add a point, the lady from chemistry had it from IIT.
Yes.
From outdoor. I did clinical picture more of a sensitivity like this. They were at
So our diagnosis was correct. Right? Yeah, very high. And your diagnosis was PKU theory. That was also very logical, but it was not PKU. Okay, next please.
Thank you, Ma'am Asha, for sharing the experience. Now I would like to invite Brigadier Amay Jas for enlightening us on newborn screening.
ये हमारा जो इस वक्त सेशन है, ये कितने काफी लोग और जगहों से भी लोग देख रहे हैं. इट इज कॉल्ड जूम. दिस इज जूम प्रोग्राम. जूम पे वीडियोस और ये प्रेजेंटेशन हम शेयर करते हैं उनसे. तो ये हमारी प्रेजेंटेशन, जो लोग आ नहीं सके दूसरे शहरों में, कराची में, लाहौर में, पेशावर में, वो ये देखते हैं हमारा. तो जब हम स्क्रीन शेयर करते हैं तो वो उनको हमारी स्लाइड नजर आती है. ओके, स्लाइड्स आगे वाली ऑफ करें. Thank you very much for very nice presentation. Colonel Aisha is our promising chemical pathologist. She has not formal training from abroad as I had from Great Ormond Street Hospital, but the way she has picked up these difficult techniques, and that is really very impressive. And we have a future great pediatric chemical pathologist. Please, Zishan, can Zishan come forward? Please, Brigadier Zishan, come forward. Thank you very much. For I am personally thankful to all the guests, including gynecologists, pediatricians, chemical pathologists, who have traveled on the day of their arrest to this venue and attended this small session. The topic I'll discuss is altogether a different thing than what Colonel Aisha was talking. Please, I'm talking to my younger colleagues. Some people have just joined our department. This part is for them. That newborn screening is screening of all the children who are born in a region, in a community, in a country. That doesn't mean only those children who have got symptoms. No, all children. And this is, for some diseases, I must say, it is criminal not to screen them, because they are very easy to treat. And if we are not diagnosing them early, we are doing very bad thing for them, for those babies. So newborn screening is an altogether different thing. And in a few minutes, I will tell you something about this. This is the objective. About 5 million children die in the first month of life in developing countries. 4 million children are born with some congenital anomaly. Almost 27 to 30% of the babies dying of SIDS are now proved to be having some IMD. This IMD is the latest term, what previously was called inborn errors of metabolism. So it is one and the same thing. Now they are called IMDs because people say nature do not do errors. So using a term error for nature is probably not a good thing. So IMD is a better term. And with our very first MMD with pediatricians, we agreed that we will use, I remember Brigadier Munir also guided us that we must use IMD instead of IEM. But this is one and the same thing. So about 5 to 15% of all sick units in NICU are expected to have some IEM or IMD. What is newborn screening? It is testing all the babies, all in capital, born in a community or country. If you do selected babies, then it is not newborn screening. Newborn screening is doing examining or doing testing on all the babies. It is not diagnosing children who come to the hospitals, clinics for various diseases. So this second part, who come to the hospital clinics, that was dealt by Kanal Aisha. That means the tests are altogether different. The instruments are different. Since we are laboratory people, I must tell you that is a different domain. And the newborn screening, we will be using altogether different instruments. So you should also get some familiarity of our instruments, name of our instruments also. The tests are different, requires extensive. In newborn screening, the biggest problem is of infrastructure. You have to involve gynecologists. That's why we have invited gynecologists. You have to involve gynecologists. You have to involve midwives. The major role, I think the major role in newborn screening is of midwives who will collect samples on the Guthrie card. What is there any urine test included? ये जो हमारे थोड़े से senior students हैं बताएं, is there any urine test? No, not at all. Please, ये ना कोई हमें कहे कि इस बच्चे में urine test करके दे. Urine, it is only and only heel prick drop of blood taken on a Guthrie card. There is no urine test which is used for newborn screening. What is the test for example, cystic fibrosis? में हम कौन सा test करते हैं? Immunoelectropsy. Don't advise sweat-chloride as a newborn screening. It is not possible to do sweat-chloride on all the babies. Only IMDs included? No. Many newborn screening doesn't include IMD. So, Aisha's domain is a part of newborn screening only. There are many other things also. There are many endocrine disorders. For example, congenital hypothyroidism and this congenital adrenal hyperplasia, cystic fibrosis, etc. IMDs are part of newborn screening, but they are not the only diseases. Mr. Guthrie, whenever we talk of NBS or newborn screening, we must remember this gentleman. He was not a doctor, he was a scientist, Robert Guthrie. The PKU story, crusade against mental retardation. He had a son with PKU, means phenylketonuria. He had a son with PKU. He developed filter papers to collect blood spot, which is called Guthrie card, after his name. So initially they were called filter paper, and still some of our pediatrician colleagues they call it filter papers. PKU is the first disorder to be tested. This is Mr. Guthrie in 1960s. Guthrie in 1960s he developed a filter paper test for PKU, identified newborns with PKU whose diet could be modified, thus preventing just by modifying the diet. No medicine, no therapy to be given. Just by modifying the diet, the PKU children, they became normal. In Great Ormond Street Hospital, we used to run a PKU clinic in which those babies, those children would visit, and we will test them for tyrosine levels and phenylalanine levels. And one girl, she reached at the age of 22 years, and she also gave birth to a normal baby. So it's in 1963, it started with phenylketonuria. Later on, in 1917, congenital hypothyroidism was included. Although this is not the most important disorder, because this is the most common, although it is not very common, but out of all these disorders which are tested, congenital hypothyroidism has got the greatest prevalence, roughly about 1 in 2,500. So, but it was included after the phenylketonuria. Then sickle cell disease in 1987, and cystic fibrosis in 2003, and in United Kingdom in 2004 they added this MCAD, which is a fatty acid oxidation disorder. This is very rare disorder, but it's a lethal disorder, and it has been shown that it's a very important cause of SIDS. That's why they have included it. And now it is going on and on and on. And in United States, different states have got their own program, and some of them have more than 20 disorders. Newborn screening aimed at the early identification of conditions for which early elimination or reduction of associated mortality, morbidity, and disability. So there are certain criteria for inclusion of a disease in NBS. For example, the disease commonality or prevalence is not the only criteria. Otherwise, you know, Gilbert disease is a very, very common congenital disorder. Almost, it is said 10% people have got Gilbert disease, and it is not part of NBS. In no country it is part of NBS. Why? Because it is a benign disorder. It doesn't cause anything. And whereas MCAD is a rare disorder, but it is included in this. Secondly, there should be some treatment, some management tool should be available. So that's why some disorders like leukopolysacchardosis, MPS, they are not screened because you can't do anything for MPS. So there are certain criteria for inclusion in the NBS program, and every country has its own program. It is the process of testing newborn babies for the treatable genetic, endocrinologic, metabolic, and hematological diseases. There are 3 or 4 things included in this: the blood spot test, newborn hearing test. I do not know the details of how it is done, and then the physical examination. And lately, they have added a test for the severe cardiac diseases, in which they do pulse oximetry in the first 2-3 days of life to detect severe congenital cardiac disease. Okay. In almost all European countries, starting in 1964, phenylketonuria, congenital hypothyroidism, CH, this MCAD, biotinidase deficiency, sickle cell anemia, and the test done almost in every state of the United States. They are congenital TSH, PKU, benign hyperphenylanemia, and this transferase deficient galactosemia, and this is hearing test, which is abbreviated as HAIR. Endocrine disorder, CH, blood cell disorder, sickle cell anemia, and maple syrup urine disease in some states, homocystinuria, and biotinidase deficiency. This is the chart showing the state in the Asian countries. China started in 81, Hong Kong 84, and in Pakistan, India, Pakistan, Bangladesh, there is no national program, but in our neighboring country, they have started some regional programs in some hospitals. Guthrie card is an essential feature, and you have to take blood from the heel prick, not from the umbilical cord. This is very important lesson to be given to our midwives and the paramedical staff, that it should not be an umbilical cord sample. And by second, third day, umbilical cord is not there also. Blood spots spread properly over these circles, used all over the world. Midwife has got the major role. Dispatching of the Guthrie cards is the responsibility of the midwives, and we can also work on this aspect that they should send us those cards. They are very important in the chain. In the lab, we have got a punching machine which we call puncher. In that punching machine, those blood spots, they are broken and they are taken in these wells, like ELISA wells, and they are then tested in the machine. Delphia is the equipment, or the Delphia is a technique. कुछ हमारी बात भी सुन लेना, इसलिए मैं टेक्निक का नाम भी लिखा है. This Delphia is a most modern technique for screening. The good thing about Delphia is that it is not very expensive. It has got greater sensitivity, but not very high specificity. So it qualifies to be a screening test. So if a test is positive on Delphia machine, it has to be confirmed by our regular system, which is chemiluminescence, which we use in our diagnostic lab. So we are starting this, inshallah, under procurement, this Delphia-based machine. But you know, there are a lot of red ribbons and red tapes and on every day we get a new objection. The letter of credit has been opened, but still there is petrol inspection, etc. The machine costs about more than 2 crore rupees with the puncture. And we plan to start with congenital hypothyroidism, CH, cystic fibrosis, galactosemia, and vitamin days. And we may add PKU also in it. All babies born in MH and CMH will be included for mandatory screening, but we will be open for all the similar patients who want to participate in this program. Timely sample collection, they are the standards. They have developed the standard how to work on it. Timely sample dispatch, completeness of coverage. No baby should be left who is not included in the program. Tracking of the babies with positive result, timely identification of babies for whom the laboratory has not received a decline notification or blood sample. Timely processing of positive screening samples. This is very important. For example, if you diagnose, if there is a positive for CH, that means congenital hypothyroidism, and TSH is raised, then it's a sort of, not exactly, but it's sort of emergency that you must get it confirmed on a routine test, chemiluminescence, and must inform the caring pediatrician, and so that the thyroxine should be started as early as possible, because a delay in 1 day of starting thyroxine may cause the lowering of IQ of the baby. This is the chart, sample collection, sample specimen transport, analysis, referral, presumptive positives, definite diagnosis, etc. So there has to be a very elaborate system right from the midwife to the laboratory and then reporting back. Inshallah, we will develop that. We will be holding such meetings more frequently. It's not an easy task, it's a great challenge, but I think it is time to has come that we must start it. Today, we have got representatives from ZB Foundation. They will, immediately after my talk, they tell you what they are doing. This is an NGO which offers free MBS screening free of cost, currently only for TSH, for hypothyroidism. They have got an also link from MedLab Jordan, which to a certain extent they offer confirmatory test also for certain disorders. The 3 card will be available through FIP, and we will communicate you the results if there are any positive results. We will not communicate negative results, but we will communicate positive results. So Dr. Ali will now elaborate about the program. Ajay, Dr. Ali, please. Any questions about NBS?
So if the cost is so high, is the incidence for medication such to justify the cost?
This is a very important question. Actually, cost of, yes, it involves money, but cost is not that. I told you these Delphia tests, screening tests are much less expensive as compared to the chemiluminescence. So, but of course, the cost involved, the initial cost of the instrument, the infrastructure cost, the running cost. But can you compare the cost of cretins, the hypothyroid idiots who will produce in the community? Is that cost greater, or this screening them at birth? The cost of a child with PKU and the child with MSUD, etc. So those rich countries, they have got money, they have money to spend on this, but they are not stupid people. Yes, IRT is included for cystic fibrosis, immunoreactive trypsin. Yes. Any other question?
So what is going to be the current cost?
We have not yet determined it. Of course, for entitled patient, it will be free. And this pilot project with ZB is absolutely free. We will be sending them the cards and they will be doing. But I have visited them. They are very nice people and they are offering a great service. But this system is not that big that can take the load of all of 40 or 50 deliveries per day. So ultimately, we have to resort to our own system. But in the meantime, we can get trained and we will get used to it, how to send the 3 cards, how to get reports. But our collaboration with ZB will continue. And currently, they are offering only for congenital hypothyroidism. Whereas in our system, we will be doing for 5 diseases. And for CLE, we will determine the cost and will communicate to you, inshallah.
What is the cost of amino acid UTS screening?
We charge for private patients, which is very, very low. Huh? 5,000. 5,000 per specimen. No. We discourage urine because that urine has a corrosive action on columns. So we recommend use of plasma, the heparinized plasma, and the CSF, of course, CSF. No harm in sending CSF, but not urine. Please don't only for Fanconi or very rare disorders you may send urine. But this is our. So we have shared also this why we hate urine for amino acids. 3 urines, yes. But for for organic acids, they are requesting you to send urine. And she showed you the slide. There is a list of 56 organic acids. We are just 1 month short of this starting this facility. The latest objection we have received from Germany that will you use this for forensic testing? We said no. This is for babies, not forensic. Whenever something goes from Pakistan, they are very skeptical and they ask a lot of questions. But inshallah, hopefully, we will get them soon. Yes.
Can you get necessary for research purposes?
Yes, why not? This risk, I think this will go a long way to reduce the word about our community. And we would like to collaborate with any institute. But if you happen to see articles from New England Journal of Medicine, they have 50 authors, they have 100 authors. The list of authors is in an annexure, separate annexure. So don't worry about number of authors. All pediatricians can be included, all gynecologists can be included, from military, from civil. Anybody who wants to collaborate with us by sending sample. Just we require the filling of that pro forma and sending sample. And this Rawalpindi IMD score, inshallah, will go. If you allow me, I just want to repeat what it is. It is for the developing countries. Because these facilities, diagnostic, I'm talking of now diagnostic facilities. These diagnostic facilities are very costly. We cannot afford to do these tests with all the babies. So we want to select which babies should go undergo these tests. So if the score is more than 6, strongly recommended. If more than 4 and 3 to 6 is yes, you can do it, but less than 3, no, not required. So this score, inshallah, we will present to the world, and I have a dream that our article is published in New England Journal of Medicine, because this is the quite novel thing. I have not seen any such publication where such a score is available for IMDs. So I think we will. Please. Please. अगर वो उसको ऑन कर ले.
This big step taken by the chemical department of AFIP. It's going to be a giant leap.
Thank you.
In managing the newborns, in managing the problems with newborns, and I'm sure it's going to be very cost effective. It is something which we as neonatologists have been advocating. You know, we've been
yes. You will part.
Last 2 years, let's say, please start something. And I had a talk on newborn screening a couple of years back.
Yes.
So I think we are very happy, and it's a big problem.
Thank you very much.
From neonatologists and pediatricians' point.
Thank you. And I second Colonel Zishan that he was our speaker for the last 2 years in our seminars on such cases. Yes.
like to add the failure tomography cases which we have registered for the past about
No, sir. It has got very poor specificity, sensitivity, and we cannot report on TLC. And we are almost in the process of closing that investigation. नहीं retrospective. हमें वो परफॉर्मा बिल्कुल ये प्रोस्पेक्टिव स्टडी है. इसमें परफॉर्मा फिल होगा तो इंक्लूड हो गए.
Is not all that low in our center. They have started it in Lahore.
Yes.
Fatma Memorial, Dr. Tariq Zafar has done a preliminary pilot project on it, and he also did the country thing. It came out to be 1 in 1500.
Okay. Yes, you are right.
Which is far higher than what
yes.
the books, which is 1 in 4,000 and some literature quotes in 1 in 2,500.
Yes.
It's around 1 in 15 to 60, which is not all that.
Colonel Talal is absolutely right. First thing is, we do not have data for ourselves. What I quoted 125 is literature broad. So that hospital-based study or good addition, and we can have our data very soon, just in 2 years. Just on a lighter tone, when Aisha was presenting those 2 cases of urea cycle defect, I was praying to God that Talal should come, and Talal entered in the room. So I thought I should have asked something else, because he is the person who sent those 2 cases to us, and that give another. आप जैसे कहते हैं ना अपनी गलतियों से सीखते हैं, वो दोनों पेशेंट्स में बिलिरुबिन ज्यादा था, तो we thought, sir, please welcome Major General Farooq Ahmed Khan. He is patron of, sir, please वो सीट आपके लिए खाली है. खाली क्यों है सर? खाली रखी हुई है आप. Please sir, please. ये हमारे मेंटोर हैं, उस्ताद हैं, और कईयों के उस्तादों के उस्ताद हैं, दादा उस्ताद हैं. So thank you very much, sir, for coming. So TLC.
Advocate the TLC because the lymphomas were diagnosed by HN stain. There was a whole registry over here, and when the immunoperoxidase staining came, the scenario changed. With regard to TLC, we have collected a huge amount of data, and the diagnoses were there along with the standards. So arrival of new technique need not, swap away the previous technique which was being.
नहीं सर, उस पर स्टडी तो पब्लिश हुई भी है, हो सकती है, लेकिन ये जो रिस्क स्कोर में हम नहीं कर सकते ना, ये तो पर्सपेक्टिव स्टडी.
But you have got a baseline, you have got a baseline, and there were the cases which were being referred by the Department of Health.
Yes, I know. सर वो तो कोई प्रॉब्लम नहीं है. मैं आपको कह रहा हूँ, जिस कोई भी यूनिवर्सिटी, कोई हॉस्पिटल, they can come to us, sign an MOU with us, and they will be part of us. आपको पता है दुनिया में मल्टी सेंटर स्टडीज जो होती हैं उनको ज्यादा वेटेज दी जाती है, तो पता नहीं हम अपने मुंह में क्यों बंद रहना चाहते हैं. So we extend this offer to anybody, civil, military, from Lahore, from any Peshawar, if they want to, but we will sign an MOU so that the things are written, because the people change. हम कोई और आज कोई और लोग आ जाएंगे, तो एक writing में सारा कुछ हो, so we can work on it. No, absolutely no problem. So, Colonel Talal, when we got those tests, our problem was, what should we do? Because there was a death of the sibling, the patient was having fits, and we had the peaks. Strongly inclined. So one thing was we ignore it, that is not a significant finding. The other was, okay, we give suspicion of urea cycle defect, and then we can confirm it. So that was the safer option. So we went to the safer option, and still, so one of the patients happened to be known to me also. Later on, their parents are known to me. They were from the South Punjab, and I have still advised them to monitor by ammonia. Ammonia is a very good test for monitoring. So raised ammonia, absence of acidosis, death of a sibling, history of fits. So it was safer to give the diagnosis. I know that asked you a bit, but now we can say most probably they are not having a serious second.
What we did for the internal period of time was that we procured protein-free milk.
And you started that?
Started it just for 2-3 days. And the moment you said that
they are normal.
Samples are clear now, so we shifted that.
So that is also one of the reasons that I still advise them this ammonia testing monitoring, because stopping that they may not go into the bad things again. Urea cycle will always remain a challenge for us. I must tell you, in urea cycle there are multiple enzymes involved, and these amino acid analysis, they do not cover all the enzymes actually. They just cover 1 or 2 enzymes. So if the amino acids are normal, we cannot exclude urea cycle. For a urea cycle diagnosis, we have to do the enzyme analysis, and that is not a very big deal. We will inshallah start doing it. That just requires a fluorometer, and on fluorometry we can start it. I think I will advise invite now Colonel, Dr. Dr. Ali Rizvi. Since it is on the Zoom, I have to do it myself.
इसी पे टैप से चलेगा
जी टैप से इससे भी चल सकता है
बस टैप से करो I just have to press this one.
Yes.
Please. Thank you very much. Assalamu alaikum. I'm Dr. Ali Raza. I am working as a primary care pediatrician in a private setup in Islamabad. So next thing, I'll move on to the introduction of our welfare trust. It's basically a welfare trust. I was just wondering that how I would start. It has become a very highly academic and technical session as well, and very nice talk by Dr. Aisha and Brigadier Saab, and very informative as well. So I always think that this is an ocean actually. And I was always wondering as one clinician that where we would go, which direction to move. But after coming here and listening to all what they have said, I'm happy that our boat can follow their ship. Well, in a big ship, you always need lifeboats. So we might be one of the lifeboats. And for us, this can be the lighthouse. Anyhow, I will just introduce this welfare trust to you and then we will move on.
अच्छा ठीक है
so lights are off करते हैं sound इसमें अगर हो sound
साउंड में कुछ प्रॉब्लम आ रही है आपको बता
actually this is a story about a family and the woman you just saw is the mother and this baby is the child. This is an adoption actually. This is a British woman. She married to a Pakistani person, and both of them, at their marriage, they decided that they will have a poor child and they'll give a best life to the poor child. So they came to Pakistan. They are settled in Dubai. They came to Pakistan. They adopted the child from a very poor family, and they got initial examinations done. They stayed here for like 2 months. They got all the papers done, and they legally adopted, and they moved back to Dubai. In Dubai, she fell sick at the age of around 3 months or so, and then she was referred to a metabolic unit, and where she was diagnosed as suffering from one of the metabolic disorders. Now, the doctor there, the metabolic unit head, Dr. Fatma, asked this lady that, didn't they do the Guthrie test in Pakistan? Then she called back to one of the hospitals from where she got her examined, her first examination. And obviously, we are not doing it as a routine. We are not offering it as a routine. It's not in our minds as well to offer this test to anyone who comes to us. So then when she came to know Now, this was their first child after the marriage. So she was very much disturbed. So how I came to know about this family, actually, this baby also came to our clinic once or twice for routine issues. So I met the grandfather later on, then he told me that this baby unfortunately passed away. And then the mother was so concerned, this lady, that she started getting information about this screening programs. Her sister is a nurse in UK. Then she talked to her, then she told her that normally we are doing certain 6 or 7 tests in UK for every child and certain other tests on recommendation of pediatricians. Then she contacted Perkin Almers and she said that this thing is not in Pakistan at all. So the Perkin Almers helped us and they donated the instrument that Dr. Amil just mentioned, although it's semi-automated plus manual instrument, the same instrument that he mentioned in his slide. So this is how I came to know, and they said that we have made an organization, a welfare trust, Zahra Biao Naqvi Foundation Welfare Trust, out in her memory. Then I was wondering, I said, how would you move? What would you do? Obviously, they had no idea at all, and they are not supposed to know as well. So I said, if you allow me, I can help you. I'm working voluntarily for them, actually. So I said, let me help you, because I know this is a very hard task, and we have to introduce, I don't know what we would be doing. And all these things that Dr. Ahmed just covered in his slides was our dream. But bringing everybody together on one platform was the most difficult thing. And I hope, inshallah ta'ala, as Dr. Munir is also involved, pediatricians are involved, they can bring it onto the PPA forum as well and bring in all the pediatricians across our country together on one platform. Anyhow, the story continued. This lady has her own 2 twins. And then she adopted another child because they wanted to do what they pledged for, and they are happily living now. And actually, all the funding, they are raising it over there in like family functions, things, and other things. This machine has been donated. Kits are donated. We have 5 kits. They are donated to us so far. Anyhow, moving on. The mission is same what Dr. Sab said. So I was wondering that how can we do? But again, he mentioned one very important point, that it is really difficult to reach out to people. So I said, because their department, their hospital, their, you have limitations. The one thing about us is no limitations, to be very honest. So what we are doing is we are going to doctors ourselves. We are reaching out to the individual hospitals where they have busy neonatal units, the gynae units. Yesterday, I visited Peshawar. I visited Hayatabad Medical Complex, and then I went to the Khyber Teaching Hospital. 2 weeks back, I went to Lady Reading Hospital. And wherever we are finding any person who can join us, the consultant is interested, we are reaching to them. So, and a good twist of fate that we came across Dr. Ahmed. He is very enthusiastic, and we are very happy that we have the same mission together. So our point is to make inherited metabolic disorder, this IMD platform, or I enabled IMF once in a meeting, that is IMF of Pakistan would be, this is inherited metabolic diseases forum, but not the other IMF, I mean. Anyhow, so I would like that our worthy seniors should work on it and make one platform. We should have our own national recommendations that we should be doing these tests. And we have pledged that we will be doing it free of cost for everybody. This is just a brief introduction. These are our supporters. And in this process, because they are settled internationally, they have chosen one of the best auditing firms that have the international standing, the Ernst & Young. They are doing our audits so that all the nations, wherever you take this name, it's guaranteed that they are doing the fair business. Nutricia is also helping us in treating patients, getting us help, clinical help, and other things. And Perkin has already donated us the instrument, and they said, if we develop the network and we have the data and we do it, they will be giving us a mass spectroscope as well, all free of cost again. These are some of the supporters. These are the same consultants I just mentioned, Dr. Khalil, Dr. Fatma, and others. And Dr. George, not to mention, I don't want to miss him. He's the person, he owns a lab, Med Labs in Jordan. We met him in Finland when we went to one of the Perkins function, our board members. And he was very helpful. He said that he would like to help us. Then we went and we visited his lab as well. They are doing whole range of metabolic disorders. That he is the person who trained our team as well, because they are using the same instrument. And we are constantly in touch with him. And he has given us the option that we can send him the samples for detailed screening as per recommendation, as Dr. Amar said. So we are really grateful to him. I don't think so that, again, the same thing that Dr. Amar mentioned in algorithm, this is the same thing how a sample would move, and so I'll not waste more time over here. This is what the Delphi will do. It is very much familiar to Dr. Amir. It is basically, we have two monoclonal antibodies that they have taken from mice, thanks to the mice. And they are already in the wells that he mentioned, that you put that. And it's an antigen antibody reaction, which is sandwiched, and then you wash it away, and then you measure the this fluorescence, right? So this is the brief about it. So here many steps count. We have to be very careful. Washing is important, and the sample is very important, because if you have a lighter blood spot, you're going to miss it. You have less of the washable stuff that you're going to bring in. So if you have a double drop on it, again, it is going to be it will be having more of it. So you have to be very careful while you're putting the blood drop on the Guthrie card. It should drop it. You should drop it on it and let it soak horizontally. Don't even twist it, because if you twist it, when the blood is fresh, it can just tilt to one side, to the dependent side. And you have to take a punch out of it, as he said. So we are taking the punch from the back side where it is homogeneous to have the best results. Now, he said, as he already informed you, that we are just doing in Pakistan one test, that is TSH. Why did we go for it actually? Again, the point is there, as one of the speakers also said, one of the participants said, that it is very common. Although we are thinking 1 in 3,500, 2,500, that hospital study is 1 in 1,500. My point of selecting it was that we can get it confirmed in any lab, number one. Number two, the treatment is available. It can be followed up, right? So I said, everybody's familiar as well. Even parents are familiar about because most of the good hospitals, they are writing on the discharge slips, please get this test done in the next week and get back to us with the results. So that was my point. Sorry. Anyhow. So that was my point of choosing this. But it has certain limitations. There are different newborn screening programs, as you already know. In North America, they are following T4 and TSH. Primarily, they are doing T4, and with any low T4, they will be going for the TSH. But on the European side, they will be going for TSH first. So when we are doing TSH first, we are likely to miss normal TSH with low T4s and thyroglobulin-related issues and the central causes as well. So in this say, while we cover for all these plus and minuses, we do the T4, we do the TSH, we do everything. Even with everything done, we can miss 6 to 12% of the cases. So again, in my opinion, in everybody's opinion, the clinical suspicion remains the gold standard always. Even if you have a normal test, please don't rely on it. Keep following the patient. So this is the thing that I just mentioned. I would say I'm not adding anything, to be very honest. I'm just telling you what I know. So then we developed a program that we developed this chart with us. It is here with us if anybody wants to see. We are providing it to those units who are taking the samples. And this is information about the sample techniques. And you can see the blood spots there. The first one is the good sample, a good size drop, a homogeneous drop, very fair, very nice. Next is also okay. It is slightly lighter, but it is okay. So then you're not acceptable. Few drops, scattered drops, and when you look at the back side, you may not have the same picture on the back. On the back, there might be just a pin drop. And then anything that is doubled up or anything that is very lighter is also rejected. And calling, first thing, it is very difficult to have the patient with you after 48 hours. And if you have it by your luck, then it is very difficult to call them back. So we should be very careful when you're taking the samples, because everybody is anxious, the parents are anxious, the doctor is anxious. And especially when we are doing something new here, we are also very tense. So this is the information that we provide to all the units where they take the samples. And wherever we are providing these things, we are providing with the 3 cards, we are providing with the Lancets, we are providing with the alcohol swabs, we are providing with the courier services. They just have to take the sample. Unfortunately, or maybe I don't know, one of the hospitals said even appoint the person here to take the sample. So we are working on it. So I said, okay, we can pay the average pay, but he's asking for double pay. So let's see. We will definitely put a person there because there are a very high number of births there. That's just sharing. To this extent, we are ready to work. Obviously, if we spread this word around everywhere, definitely we cannot convince people. So that's why we are going hospital to hospital, institution to institution, department to department. So head order departments are basically taking the decisions. So that's why we, I don't know if we approached him or he helped us out. It's both ways. So we are with you as well. These are the hospitals. We are getting high-risk cases, as Dr. Ahmed mentioned. We are doing it on request. Whenever the concerned doctor is saying, Dr. Shahid has been very helpful, Colonel Shahid, because I met him during the PPA meeting few months back, and I said, this is it. He said, who are you, and how are you getting the funding? So he said, okay, we will send the samples. And that was the easiest start for us. Anyhow, they are just sending the high-risk cases. And definitely we would like if they can also send us the routine TSS to Brigadier Army. In KRL, we are doing it on routine. BBH, we are doing high-risk screening. NESTOM, Pakistan Atomic Energy. KICH is basically Khyber Institute of Child Health, where the dean is Dr. Gohar. They have like 6 districts. So currently we are focused on Peshawar district. Then we will move to district. And even private hospitals are welcome. So there is actually, this is the, we have just distributed few here along with our brochure. This is a white background paper that is it carries just general information that we tell them that distribute this while you're discharging the mother and the baby. And on the back, you can put a stamp or you can write on the discharge slip that you will come on such and such date when the child is 2 days and get this test done free. All our cards have the stamp of free test. Do not pay anyone, and we have a number as well. If anybody charges the money, let us know. So this is just it. Now, all aims and perspectives, everything has already been discussed. So I will not stay here. We are all together, and I would like that if we can take everybody together. And as he said, this ship should be big enough to accommodate all the Pakistani children. And we owe them a lot actually. Being doctors, we owe them a lot. And we should work with this mission, with this thing in our minds. And people would say that this is maybe, I don't know from where the funds would come. I don't know from where the funds would come. But I was always thinking that if we have something gone wrong with our instrument, alhamdulillah, they'll be having the instrument. We'll be sending the samples here. So the good thing is that business has started in Pakistan. That's the best thing about it. So everything is being done. We are training the staff, we are training the doctors, and we are personally visiting each and every hospital who is interested. Anyhow, nothing is new in this, what I said. Everything has already been told by Brigadier Saab and Dr. Aisha and everybody. But there is only one thing new in Pakistan. That is our team. Unfortunately, I don't know who is in our team, and it's you. Everybody's there in the team. So this is not a team of one Dr. Ali or Dr. Aisha working with us, or Fiza working with us, or Irfan working with us. No, we are the team. That's it. I'm really grateful. Thank you very much. If there's anything that I can answer.
I have a question.
Yes, ma'am.
First of all, congratulations for the good work that you're doing.
Thank you.
Pakistan still has very good people around. That's why this country is going on.
Thank you very much.
The other thing I was interested from your discussion, what I gather is that the best timing would be 48 hours later to collect your sample.
Yes.
This would prove to be the biggest challenge in sample. Because we discharge our patients within 12 to 24 hours. But I think we should be great motivators and emphasizing the necessity and the goodness, and then patient awareness campaigns would increase the sample. They would come back and give the sample. Because we cannot have an inpatient for more than 24 hours, or hospitals have limited capacity. We cannot keep them for 48 hours to get the sample.
I agree, madam. This is a very valid point, and we are facing this difficulty as well. But the point is, When we have to follow, yes, when we have to follow something, we have to do it and keep doing it, keep doing it, keep doing it. Just like learning a bicycle. How many times I remember I fell? I had my shins torn off, the clothes and everything, but I didn't let it go. So I learned the bicycle, I learned the car. So I think we should keep on doing it, and we should educate our doctors, we should educate our public, and I hope and inshallah they will follow, definitely. Yes, yes. Of course, ma'am. Yes. Of course. Yes. So.
Thank you very much for a very inspiring talk. Just two short questions. Firstly, do you know the diagnosis of that first patient?
Which this is type 2 glutaric acidemia, sir. Type 2 glutaric acidemia.
Do you plan to expand your test?
Yes, sir, of course. Actually, this Dalphia does 5-6 tests, as Brigadier Amar mentioned. Each test has a different kit. So my point was that we should focus on a common thing, reproducible thing, confirmable thing, treatable thing to make our network. Once the network is in place, we'll be awaiting national recommendations from all our seniors. And they say, okay, in Pakistan, we should be covering 5 more tests, 10 more tests. As Dr. Amar said, that we will be sending only those which are needed. So we'll be waiting for that time to come. So I hope by that time we will be adding up the tests. Yes, because G6PD is a very common finding in the high risk patients that we are sending. So it's worth it to have it in our panel as well. That can also be done on the same Dalphia.
I really appreciate the decision to go for one project to start with research of the screen-put-in hyperparathyroidism policy. Because not only it's common, it affects the body people with quality of life is not. When this starts with the USP, the work in the 8 months old, and kids don't have the parents, obviously benefit from it. We've seen patients in the treatment starting with first food, they are doing it with 50 times. So I think I really appreciate this. We have to go for a second test.
Thank you.
A few days back, I had a call from one of the pediatricians in Islamabad, and the child was delivered at our facility 2 weeks ago, and they were asking me whether this child has been screened for congenital hyperthyroidism or not. They were asking me whether you have done some kind of newborn screening, and I was totally at a loss. Today, I think I advise her because the team we are developing, we are moving towards that.
So I think we must advise them on discharge and tell them verbally, please get it done.
I would like to ask a very important question because I'm stationed in Lahore. I'm working as an assistant professor in Shalimar Medical Training College. If I want to invite you to come and see our setup and help me establish it, would that be possible?
Of course, this is what I said. I visited Peshawar yesterday, and I can come any day, preferably Friday because I take off on Friday. So we can come. We can straight away start it there. Straight away.
I tried to start it.
Yes, of course we can come. We can come.
I couldn't recall the time.
Of course, we'll bring everything with us and we can start. Of course.
The foundation is doing a great job by offering SPG to all the people in Pakistan. But sir, is there any plan to extend this facility and then also start, like if we diagnose a patient with certain metabolic disorder and then like the protein-free diet, so is there any plan to support those families?
We are already supporting 2 families. With the help, we are paying them actually nutrition, the cost for the special meals. So the aim is to develop the food, yes, and gradually get the donors as well. And where it helps, it can help. Where it matters, definitely we will do all our efforts to get the treatment. Definitely, yes, but we have to take a start actually.
Thank you very much, Dr. Ali. Excellent talk and very informative. And may Allah bless you for doing this great job. Before going to the next speaker, I just want to request you that if we do such meeting, not exactly like today's informal sort of meeting, once a month until for this. So, but I will suggest, I will request Vidya Lodi to suggest some day and venue for once a month, monthly meetings, such meetings, and we can also invite Dr. Ali for that meeting. So आप सर अपने डिपार्टमेंट पूछ के अगर वो फ्राइडेज वाली में एक फ्राइडे में दे दें आप, ठीक 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 जी. नेक्स्ट स्पीकर इज डॉक्टर सफिया, प्लीज. इंटरव्यू देखना पाएगा.
इसमें नजर आ अच्छा आ रहा है. Is it 48 hours strict not mandatory or is there a range?
High levels in the very
And have to come down after 48 hours?
Look, in first 24 hours, it may be 100. So, another project we can do, that we can establish a reference value in our population at 12 hours. There must be some cutoff.
If at all you are going to do it, why not do it on simple after daily basis? 1 day, 2 days, 3 days, 4 days. Because sometimes you may get a guy who may be 3 days. Up when you are establishing references.
Yes.
You are trying to so you must go for
yes.
Over the entire
for that project, yes, we can do.
Ideal period is maybe on day 4 to 6.
Yes.
Because then the reference is.
If we find that
earliest period is 2 days, but
yes, this is current recommendation.
As you go big, the more than the discrimination level.
So at that time, actually, the techniques were not so good, and probably the patient will remain with you for longer time. Now it is within 24 hours, within 12 hours to the starting patient. So we have to resort to this 12 hours, and we have to do a project, determine our cutoff. Otherwise, I tell you, patients do not come. Once they are discharged, especially the private patients.
I can tell you the problem. Then you will go to 12 hours. The discrimination between healthy and sick.
So we have to establish the cutoff.
That's a good idea.
Cutoff.
People talk about admission to be doing
Okay. Next up. Yeah, another topic.
Second. Bismillahirrahmanirrahim. Respected seniors and fellow colleagues, Assalamu alaikum. In the next few minutes, I will discuss the salient feature of maternal serum screening at AFIP. As we all already know, that ultimate aim of maternal fetal care is the uncomplicated birth of a healthy baby to a healthy mother at term. I shall follow this sequence as flashed. Maternal screening play a major role to detect chromosomal abnormality like Down syndrome, Edwards syndrome, neural tube defect, and other inborn disease of newborn worldwide. It should be offered to all pregnant patients both in the first trimester and in the second trimester. The most important challenge in screening is to have a test that has a high detection rate and a low false positive rate. Detection rate, in another word, is called sensitivity, which is percentage of effective. And higher the sensitivity, better the test. While the false positive rate is percentage of ineffective, and the best screening, it should be lower.
Maternal serum screening consists of two types. First trimester maternal screening, which should be done in 10 to 12 weeks of gestation. It consists of biochemically two parameters, that is pregnancy-associated plasma protein A and free subunit of beta HCG, and ultrasonographically knuckle translucency. While second, most common second trimester screening include two panels with different composition of test. This is triple panel and quadruple panel. These serum markers in the second trimester are useful in determining the risk of developmental and chromosomal anomalies. These tests include alpha-fetoprotein, human chorionic gonadotrophin, unconjugated estriol in the triple panel, and inhibin A in addition to these in quadruple. These four tests carried out during second trimester has been shown to have a higher detection rate and higher performance. Confirmation is done by different prenatal testing, most commonly chronic villus sampling in the first trimester and amino synthesis in the second trimester, and confirm already mentioned disease cytogenetically. As we are focusing only on second trimester maternal serum screening, which was historically started in 1970, when it was found that the neural tube defect was associated with increase in maternal serum AFP. With a cutoff of 2.0 multiple of median, 85% of neural tube defect would be screened in. And with a threshold of 0.5 MOM, approximately 33% of Down syndrome fetus would be screened in. With triple panel, sensitivity increased to 65% in all ages and 85% in those about 35 years of age. Recently, with quad screening, sensitivity increased to 73% in all ages and 93% in those about 35 years of age. Since the concentration of these markers show immense variation during various stages of pregnancy, it is neither possible nor useful to determine their pregnancy-related reference ranges. The method of comparison used for these parameters is called multiple of median. It is universally used in the screening programs all over the world instead of reference value. Every country or the area has to determine its own median value before starting this service. In Pakistan, there is no authentic data with median value of these biochemical parameters. Our study will be the first project in otherwise normal pregnant women. We have started a project in relation to maternal serum screening in the second trimester with the name of the determination of medians of biochemical maternal serum markers and quantity of cell-free DNA in healthy women giving birth to normal babies by Major Noreen, Brigadier Shaila Bakai, and Brigadier Amir. The prerequisite of our study will be that 150 healthy pregnant women of 30 to 40 years of age from 16 to 18 weeks of gestation visiting antenatal clinics of CMH and MH, Rawalpindi has been registered. While patient with discordant gestational age, according to first trimester ultrasound, multiple pregnancies, lack of antenatal follow-ups, fetoplacental and chromosomal anomalies, type 1 diabetes mellitus were excluded. Essential will be excluded. Essential particulars and contact details of subject will be recorded, and 5 ml venous blood would be collected in lithium heparin tube for analysis of biochemical marker. These women will be contacted after their respective date of delivery to arrange a physical examination of their babies, and if required, these babies will be subjected to essential laboratory tests like cytogenetics to confidentially rule out Down syndrome or other fetal anomalies. The suggested protocol, which is internationally followed and as we adopted for maternal serum screening, consists of different steps. We would first calculate the lab population-based medians of all tests, included in screening like alpha-fetoproteins, beta HCG, unconjugated estriol, and inhibin A of all normal pregnant women from gestational age 16 to 18 weeks on weekly base, and make a reference value of median of about an elite for their respective gestational age. Secondly, we would calculate MOM of suspected disease. MOM is basically a measure of how far an individual test result deviate from median in a population. It is calculated by result of a patient and our lab medians. For example, if a patient came to us with a AFP at 16 weeks with AFP of 30 nanogram per ml, and our lab median was 15 nanogram per ml, then its MOM is 2. Third step in the worldwide followed guideline is the calculation of adjusted MOM, because there are different confounding factors which change MOM. Well, we change MOM value, so they should be adjusted with different certain marks or certain points. These are mother age, diabetic status, twin pregnancy, gestational age, weight of mother, ethnicity, African American, etc. And all of these factors are some adjustment marks or point. And by multiplying with these, two adjusted MOM value will be calculated. And in our case, we already exclude these confounding factors before the start of study. In the future, after this study result obtained, we will be able, with the help of you as a multidisciplinary team, to calculate the patient-specific estimated Down syndrome risk in diseased patient, which is done by statistically algorithm, which depend upon certain following factors, and final result will be interpreted as screen positive or screen negative. It depends on test combination chosen. Risk cutoff chosen. Test combination means triple or quadruple screening. Risk cutoff chosen. This means that there are two risk cutoff. One in 270 in first trimester and one in 350 in the second trimester. And method of dating used in established gestational age, whether we are using LMP or by ultrasonographical date or maternal age. Most labs in USA use triplet screening with the risk cutoff of 1 in 270 in the first and 1 in 350 in the second trimester of an age 35 years women. At this risk, initial false positive rate is 6.6% and rejection rate is 70% when LMP used as a dating system, and false positive rate declined to 6.5% and rejection rate increased to 74% when ultrasound dating system is used. The final report, which will be generated by our team, will be consist of concentration of MOM value of Meyer and elite, the Down syndrome risk estimate, which will be calculated by a certain software, and interpretation as either screen positive or screen negative, and further possible action. It is recommended that for the better and internationally accepted results, we as a lab manager should participate in external proficiency testing 3 times per year with 5 serum and 2 amniotic fluid samples. These are some suggested final reporting draft for maternal serum screening, which is used in UK. Literature review showed that how these serum markers in the quadruple screening behave in Down syndrome. Usually, all of MOM value of all these markers is 1. And in Down syndrome, AFP and unconjugated estriol values are below than 1, and beta HCG and inhibin A is greater than 1. In the past, early combined first and second trimester screening was reported as low and high risk. And high risk undergoes invasive test by chronic village sampling or aminocentesis for confirmation. But now it was more emphasis was done that on fetal cell-free DNA in maternal serum. And it was recommended that both the low risk and high risk, first their cell-free DNA should be analyzed before the invasive test. So because it has high sensitivity, and second, it reduces the chance of mortality, which is because of these invasive tests. And in the end, I finally conclude that despite of screening participation of ultrasonography, well, the biochemical testing has a major role in Down syndrome screening because of increasing standardization for all participants and availability of alpha-fetoprotein for neural tube defect. But still, as it is offered program, so ethical issues cannot be ignored. It is suspected that the fetal cell-free DNA, which is a new marker, will bring a revolution in the maternal serum screen. Thank you all.
I think this is a great step because people are very afraid of serious and diseases. And diseases have a sort of peculiar problems. Contamination, mosaicism, the reporting is difficult, decisions delayed. At the moment, we are using CDS as the gold standard information test across the entire hospital, and we have been supported by the FIP. I think this is a great step forward because, see, the earlier we identify, the better the choices, the timing, the easier the introduction of pregnancy exam. Otherwise, if we delay it, the decision making delay, there are religious issues attached to it. So, by introducing a test which is less invasive, just a blood test, is very attractive. I think we are all very excited about it. We want to take it off.
Thank you, Dr. Kada. With your permission, I can comment on this. Actually, this is again a very first step. The currently do not have RBD values. So for starting maternal biochemical screening, first thing to do is to have our own median value. Because there is no, please remember there are no reference values for maternal screening. This is a common mistake. Some gynecologists, not senior, very junior people, they send sample for maternal screening. We are helpless in that. We have to have our own median values. Only then we can use it, because then we can apply and have multiple of people. Second part of this study or this project is the self-median, and as you know, this is the most exciting one because it is just a serum sample of the blood in which we will detect the DNA of the patient. And we can go to any extent. We are just starting with the Down syndrome, but we plan to do it for thalassemia also, and then for others. And it has already been started in UK by the name of NIT. This is non-invasive prenatal testing. I don't know what extent they are using, but it has been used in NHS in UK and other countries. In America, some states they are already using it for maternal screening. At least I know one hospitalist at the Rhode Island, their program is very good, and I will be participating in the webinar. Sir.
After the study, we prepare these two techniques.
Yes, we
plan to do that.
But we are trying for our own population. But
can we replace serious?
Yes, that is
in what time?
To make the gynecologist.
maybe आप दोनों की आप लेंगे
नहीं सर अगर ये सब्जेक्ट हो जाता है तो फिर हम
नहीं हाई जिस टाइम पहले है उसमें क्या सीरियस को आप छोड़ पाएंगे नहीं छोड़ते
नहीं शेड्यूल में नेक्स्ट स्टडी में हम नहीं कर छोड़ेंगे लेकिन अगर जैसे this suggests whether
in years to come, this might replace
serious. At least for in positive cases, in negative cases, we can discuss this.
At the moment, there is a center in Karachi who sends these NIT samples to Germany or UK, and they're charging an exorbitant amount of money, 60,000 for a free.
Sending thing outside, sending patient outside.
But there are cases quite a lot of issues, transport issues,
we have to do
credibility.
Sample size थोड़ा नहीं है to be extended on a larger population because
ये
you want to wait median.
ये सब आगे बड़ी डिस्कशन जो कट ऑफ वैल्यू के लिए ना वो 120 तो सेटिंग ये हम इसको बढ़ा देंगे ये तो स्ट्रेटजी का कैलकुलेशन पूरी हो जाएगी
Also, my knowledge is absolutely outdated compared to all of you. But just a word of caution: this area is quite difficult, and you should be going very cautiously because when it would come to false positives and false negatives, there are a lot of not only ethical issues, there are a lot of legal issues.
Yes.
And one must have before you actually start depending on it for therapeutic. It would be very vital that we should go very slowly. Initially, try to have a best possible statistical basis for M1 and then use it as screening test and confirm it with the confirmatory test for at least 2 to 3 years. And once you go to that stage, that would be the time when you would actually.
This is the most important advice I would give. Very, very good advice. Because we have to move slow. But at least I think for 3 to 4 years, what is the future?
This is a mega project. And
I remember
starting the first
they were very enthusiastic to start it. They started it and landed in a lot of legal issues just in 3 to 4 months, and then they had to close the project. So, bit.
As they say, sir, a journey of 1,000 miles started.
So we have to be with you that day has to be today. But I appreciate it. But
yes,
that's just word of caution from another.
Why not? Yes.
हम ला लेते हैं। चलें आ जाएं, आप ला लें। नहीं जी रिकॉर्ड हो रहा है, रिकॉर्ड भी हो रहा है।
Now I would like to invite Brigadier Munir Ahmed Lodi to please give his perspective on the subject. Thank you.
ये मुख्तलिफ और आगे भी हैं।
Bismillahirrahmanirrahim. Thank you very much. General Farooq, Brigadier Rizwan Hashim, Brigadier Amir Ejaz. I really congratulate Brigadier Amir Ejaz for gathering us together. And this is definitely a project which is doable. Technical aspects of most of the things have been covered. As a pediatrician and looking after the departments of pediatrics at MH and CMH and in Army, I will just point out what screening program should have and what challenges we would have. And of course, this is my responsibility to give the solutions also. This has already been pointed out that screening program should be such where we should know that we are catching a disorder which has a high incidence. And it should have a robust, ethical test which can be reproducible, which can be rechecked. The disorder should have high mortality and morbidity, which can be controlled by early detection and for which appropriate, affordable treatment, affordable for our country, should be available or should be made available to make such a program a success. This is a great challenge. And of course, we have to do it. And there are studies, as they have mentioned, in neighboring countries. There are 2-3 pilot projects which are done in India and other Asian countries. In India, they are seeing that the congenital hypothyroidism was the commonest. Second was G6PD deficiency. Third was congenital adrenal hyperplasia in one of the studies, and some amino acid disorders. So when we start with hypothyroidism, a question was asked by a immunologist, I think is not here, that is it cost effective? Dr. Asma was saying that she had just seen a patient of congenital hypothyroidism who was 10 months age. I have recently, within 3 months, seen a patient, 12 years of age, from Gilgit-Baltistan, looking like a child of 2 years, mentally as well as physically. So it's definitely cost effective and has to be done. What challenges we are contemplating in our setup? We all know that for screening, the best time is after 24 hours, preferably 48 to 72 hours. And when we came to know about this, I knew this will come as a challenge. and I discussed with our gynecologist counterpart, we had around 14,000 deliveries last year in MH only, which means 20 to 30 per day. Out of these deliveries, 9,000 are from the army setup. As you all know that army is a well organized institution. So what we can do is, I think a good suggestion was given by Professor Amir Ejaz, but I would tend to disagree that we would actually try to harness these patients after 48 hours. We will develop a mechanism and we'll see how much cash we can take rather than inventing the wheel again and starting at 24 hours. As General Farooq pointed out, then we have to take the readings at 24, 48, 72 hours, and I think this will not become practicable. So what I suggest is that we can start this project in the entitled patients first, though we will enroll the non-entitled patients also. Madam Shaila will bear me out that as our hospital is a referral hospital, so many complicated deliveries are referred to us from far-flung areas, entitled as well as non-entitled. As far as the non-entitled patients are concerned, they will deliver the baby and they will like to go out, and probably only, and pediatrician will bear me out, 20 to 30% will come back, not more than that. Well, in case of entitled patients, I think we can harness at least 80 to 90% if we develop a robust mechanism. We can give it time for a second vaccination, or even BCG. It is recommended that it can be given within a week. So we can develop a mechanism. We have already 2 BCG days that if actually gynecologists will have also to be on board, that they will try to keep the patient with cesarean sections or with some complications for 48 hours for us. This will solve one problem. Secondly, we will give vaccination time within 48 to 72 hours so that they will come back and we can get the blood. Consent may not be a big problem, especially in entitled patients, but it might be in non-educated parents. Then after collecting the sample collection, it was being discussed. I think sample collection is not a big problem because you may not be aware, but we are doing Guthrie's test for Gaucher's disease, which is being done by some NGO free of cost. And we are doing these tests for the last 2 years. Most of us know the technique. And we have diagnosed 14 new patients of Gaucher's disease in the last 2 years. So that will not be a big problem. We are provided with the card. And most of our results were acceptable. Only a few were returned initially. Then the major challenge is what our pediatrician, because we are the one who are facing the patients. Once we diagnose a child with MMA or any disorder, medical diets, they are very difficult to procure. They are very, very expensive. For example, this MSU diet, it is subsidized in Pakistan, but still it costs around 5,000 rupees per pack. So how much the child will use? So whenever we start something, we have to see the logistics of the things. For example, thalassemia screening was made mandatory in Sindh before marriage, but they did not have any outlets to perform this test. So it's a very good step. As far as thyroid screening is concerned, there is no second thought. Thyroxine is available, it is very cheap, but we have problems of availability. Why? Because the profit is very less, the companies stop manufacturing it, and there is no law to pursue them, and we get it from smuggled from different areas. So we have to make it available, and I think this is a very good start. And we have to press the companies who are preparing these formulas to make it available. Number one, they are not making it available because it is subsidized in Pakistan. Recently, my pediatricians know that some of the good vaccines, A. pertussis vaccine, which was available in Pakistan, is no more available because there is a limited capacity of manufacturers to produce this vaccine, and the rates they supply are different in Europe and America and from our country. So they stopped providing this vaccine at all for the last maybe 1 year. So as a doctor community, we have to see these problems and address them, especially when we are at decision-making levels. So I will just conclude that Dr. Ali, I'm very encouraged that he said that he visited most of the hospitals. But I think it's our fault that he missed our MH, which is the biggest pediatric facility in Islamabad, Rawalpindi. But we will have more collaboration with you. And I think this forum is best that we will route things to AFIP and Dr. Ahmed Ijaz. Thank you very much.
Thank you, sir.
I'll just add one thing to it. That as far as the referrals are concerned, then we can ask the referral center to refer the patient. Yes, that can be done. That they can take the test one. It's pretty difficult to come back to the thing. So they can take, because mostly they're referred by the army members. They can take at any CMS. The other side. Just one day.
I would like to invite Guride Shalabakai to give her perspective on the subject.
Just one point to ask about one day. I think we can keep every 6 weeks one Friday for this. Okay. We have a new Friday meeting at our place. Start with you can join us, then we can have alternate way.
वैसे ये हम इंटरव्यू में भी ये आप स्टेट कर सकते हैं लंच में और
वर्किंग बहुत ज़्यादा इंटेंस होता है
लेकिन वहाँ पे एक बार ये होता है कि हम पेशेंट देख भी लेंगे जी तो ये हम फायर अपडेट भी करते हैं जी तो अब हमें कोई इन्फॉर्म करने के लिए ये जो फ्राइडे है तो हम केसेस जो हमारे पास 3 केसेस सर सुबह से भी आते हैं तो वो भी हम आपसे शेयर करेंगे प्रेजेंट करेंगे दोनों चीजें होंगी ह्यूमन के स्क्रीनिंग पे बात हो जाएगी और आईडी से
Sir, thank you very much for inviting us to this August forum where we are together as a team, the pediatricians, the pathologists, we as gynecologists, and we have come to a consensus statement. I think this is very, very welcoming to have an invasive test being replaced by a non-invasive prenatal test that can be done early, because our decisions of interruption of pregnancy, they have to be made early. It is futuristic, but for starters, I think this is a good forum where we can establish our statistics, we can establish our normal values, we can establish the cutoffs, and we can deal with the hiccups which we may be encountering. The biggest challenge is these pregnancies need to be dated well by ultrasound. We cannot rely on their last menstrual period data because they are highly erroneous. We have to have our own established ultrasound dating techniques. And I think this is a doable task, it's not that bad, but for our own gynecologists, we would like to remind them that the pregnancies need to be dated well. And 16 to 18 weeks, in my opinion, sir, is a little late start. Because how long will these screening results take to come back? A week or two? Sir Ahmed, can we have your input on it?
Yes.
When would be the results be available?
As soon as within 2-3 days.
Within 3 days. Yes. Then the patient would come back and we will convince them for an interruption of pregnancy. What we are following at the moment, we are doing the confirmatory test. We are using the combined test sporadically. The first trimester screenings and then the confirmatory test done by 14 weeks. And an interruption, if at all has to be offered, is done by 15th week. And that is very acceptable religiously, ethically, medically, it makes life very, very easy. But let's see how this thing takes off. And I think we'll be able to, if the results are available early, that would be better, because CVS will not be performed after the 16th or the 17th week. We have a fatwa also. And the amniocentesis, I find, because I've been trained in CVS, I've been doing that. I've done 1600 CVS up to now. So for me, doing a CVS is far more easier than doing an amniocentesis. The world says the learning curve for amniocentesis is easy. But for me, CVS is very easy because I'm used to doing it. And the results, you give us the results within 3 days. So the 4th day, we have the patient, we counsel them, and then the thing is.
This is again a bigger project.
Yes.
What we have presented is only the second trimester. We will also do first semester because in first semester we have to involve radiologists also. Translucency test.
Buccal fold translucencies, and the radiologist can also tell us about the nasal bone, whether absent or present. Yes. But overall, I think it's a very doable task. It is very attractive, and we are all excited about it. We discussed this in the department also. But with a caution, we would start with taking General Farooq's advice. We would be very careful in interpreting the results. Thank you very much, sir.
Probably going to be long term. People are going to change. So if we're going to make it long term and sustainable, we have an administrative infrastructure whereby even if people change, the process continues.
And that's why that MOU is very important. Because that will bring the institutes. For example, between FIP and MH, FIP and CMH, and FIP and other hospitals, Shalimar, etc. So that the collaboration continues even if the people change. So we have to make such mega projects.
It should include short-term goals, long-term goals, and periodic.
We will work out details in
this is actually very important because you have to sustain production point here is production point. हमें इसको आर्मी वाइड भी कर सकते हैं जब कॉस्ट बता दें कि फ्रीज है ओके जब आप एक चीज शुरू कर लेंगे उसको आप खत्म नहीं कर सकते अभी ये अभी साहब से हम डिस्कस कर रहे हैं कि बैठ के बड़ी जल्दी की ये कब तक सस्टेन करेंगे हम कब तक हमें कितने खर्च के दे सकते हैं कितने साल तक दे सकते हैं कब आर्मी इतना टेक ओवर कर
सर वो हमारा खत्म नहीं चल रहा है हमारा जो सिस्टम है
थायराइड स्क्रीनिंग में भी आर्मी में एज ए रूटीन
नहीं वो जो हमारा सिस्टम आ रहा है ना फुल है maybe 5-6 months वो इंस्ट्रूमेंट आ जाएगा तो देखो ये डेल्फिया का ऑटोलाइजर फुली ऑटोमेटिक उसका नाम जीपीएस है तो ये पर्सन मैनेजमेंट है उनके वो रखी बैठे हैं कि रोज मुझे नई कहानी सुना देते हैं कि आज ये इन्फेक्शन हो गया आज सर्च हो गया हालांकि ऐसी खुल चुकी है पैसे सैंक्शन हो गए हैं 20 million जी सर
एक जमाना था उसमें जब सामने बताया था
वो कौन सी
उसके रिजल्ट्स बहुत अच्छे
जी जी सर ये
आई एम बट आई एम सेइंग सो सेकंड जनरेशन नहीं था is it for example adjustment development
third generation actually इन्होंने तो कलिंग के साइड पे टेक्निक दे रहे थे तो हमें फॉरेन पिक करेंगे यूरोपियन अब यूरोपियन एड यूरोपियन एक सर लेट वो है तो लेट फ्लोरेसेंस कहता है लेट फ्लोरेसेंस का डिलेड फ्लोरेसेंस तो अगले के जो नेचुरल फ्लोरिंग है वो नहीं डिफरेंट
सेंसिटिविटी की रेट कहां तक थी
सेंसिटिविटी ये से कुछ बहुत कुछ है मैं मेन केस सेंसिटिविटी वो पूरा हाई लेवल और अभी तक सर जो देखिए सर न्यू फॉर्म स्क्रीनिंग में हमें 2 इंस्ट्रूमेंट चाहिए एक ही चाहिए जो ये है एलपी है इट इज मेनली फॉर सच टीएसएच 17 हाइड्रोक्सीप्रोजेस्टेरोन for CH CH का टेस्ट करेंगे तो 17 हाइड्रोक्सीप्रोजेस्टेरोन IRT for cystic fibrosis and bacterial for बाकी तो टेस्ट जो फैटी एसिड ऑक्सीडेशन है MCAT है ऑर्गेनिक एसिड्स के अमीनो एसिड्स के वो हम टेंडन पे करते हैं वो इसमें नहीं होते तो वो जो हमारे पास टेंडन की टॉक्सिसिटी है वो तो हम उसी को भी साथ साथ डेवलप करते हैं वो जो एलसी जिसको आप लोग टेंडन कहते हैं एक्चुअली उसका नाम ट्रिपल कॉर्ड है तो ट्रिपल कॉर्ड से हम क्या लॉस करते हैं देयर आर टू प्रॉब्लम ट्रिपल कॉर्ड और टेंडन is the most commonly used instrument in all the Europe and America for newborn screening. Medical performance is much फॉल्स आता है, लेकिन जो हार्मोन ये वाली चीजें हैं ये उस पर नहीं होती, इसलिए मैं सिंस हम सबसे इंटरेस्टेड हाइपोथायराइडिज्म में थे, इसलिए हमने डेल्टा आपको और सीएच करते, बाकी चीजें हम सेकंड पे रहते हैं, उसकी डायग्नोस्टिक फैसिलिटी हमने शुरू कर दी है, लेकिन एमडीएस इसमें बाद में।
At the end, I would like to invite Major General Farooq Ahmed Khan to give some his valuable comments for us. Thank you.
The Balkan Mountains cover most of the peninsula. These mountains are isolated peaks of the countries of Central Europe. They are farther north in the Balkan Peninsula.